Bismillahirrahmanirrahim. Today we will have case quiz number 78. Case data: 71 years old female complaining of painful ulcer of the right lower leg, as you see in this picture or this photo. The patient also complaining of worsening fatigue over the last 6 months and the progressive loss of weight over the same period, 6 months. She was known to have rheumatoid factor positive rheumatoid arthritis diagnosed over 40 years ago. So she had long-standing rheumatoid arthritis for about 40 years. Her disease had been difficult to control and she had undergone multiple joint replacements and the spinal stabilization. So the disease was poorly controlled. Of course, because she was diseased before the era of biologics by very long time and even some traditional DMARDs. A past history revealed recurrent leg ulcers in the past, but was concerned that this current ulcer was non-healing, intensive, painful, and often bleed. Examination: there is large circumferential ulcer on the medial aspect of the right lower leg, extending upward from the ankle and oozing blood. Investigation: hemoglobin show anemia, but normocytic normochromic anemia, white BCs within normal, platelet within normal, sodium and potassium within normal, urea, creatinine within normal, but CRP and ESR are elevated. So, what is the diagnosis? The answer is, take a breath and think what could be this case. In fact, there is a differential diagnosis for this case, but the answer or the most suitable answer is rheumatoid vasculitis. Rheumatoid vasculitis. In fact, the possible causes of leg ulcers in patients with rheumatoid arthritis are numerous. Patients with RA are predisposed to the development of chronic leg ulcers, the etiology of which is commonly multifactorial. Venous insufficiency, vasculitis, and impaired arterial circulation are the most common precipitating factors. Bioderma gangrenosum is a rare cause. Local malignant changes and infection are reasons why there might be a delay in healing. Systemic rheumatoid vasculitis often present as a cutaneous vasculitis with enlarging leg ulcer. Vasculitic ulcers are characteristically deep and painful and are typically found in the areas of the medial and lateral malleoli. They are caused by a necrotizing vasculitis of medium-sized arteries, which is histologically similar to that seen in polyarteritis nodosa. Venous ulcers commonly occur on the medial side of the leg. They are often associated with varicose eczema and local edema. The surrounding skin is thickened with hyperkeratosis, and there may be progression to chronic lipodermatosclerosis. In contrast to vasculitic ulcers, venous ulcers are relatively painless unless infected. So vasculitic ulcers are painful from the start, but venous ulcers are painless unless infected. Venous ulceration is due to chronic venous insufficiency and is largely a downstream effect of venous hypertension. Risk factors include varicose vein, deep venous thrombosis, previous trauma or surgery, advanced age, and immobility. In addition, chronic steroid use in rheumatoid arthritis patients further promote ulceration by increasing skin fragility. So, steroid per se may cause skin ulcers. Arterial ulcers are usually found on the feet, particularly at pressure points such as heel and toes. The ulcers appear bunched out with a well-defined border and are characteristically painful. The patient will usually have other features of arterial insufficiency, including pale, cool feet and leg pain on exertion or elevation. Arterial ulcers occur as a result of arterial insufficiency caused by atherosclerosis of the lower limb arteries. Patients will have an impaired ankle brachial pressure index (ABPI) on clinical assessment. In pyoderma gangrenosum, lesions often progress quickly and may start at the site of minor tissue injury, often first appearing as a small red papule or nodule. Breakdown of the skin then results in the formation of a painful ulcers. Classically, there have been a well-defined border and are violet or blue in color. As the lesion enlarges, the edge may be undermined and the surrounding skin can become indurated. Several ulcers may occur at the same time. This is the pathogenesis of pyoderma gangrenosum. So, what about the current case? In the case history described, the painful non-healing ulcer in a patient with long-standing seropositive rheumatoid arthritis raises the possibility of underlying rheumatoid vasculitis rather than arterial or venous insufficiencies. The additional constitutional symptoms of fatigue and weight loss are typical. Rheumatoid vasculitis usually occur in long-standing rheumatoid arthritis after the inflammatory arthritis have subsided and patients are left with widespread joint destruction. Patients are usually positive for rheumatoid factor and have rheumatoid nodules. The onset of vasculitis is usually associated with constitutional symptoms. However, some symptoms such as fatigue, myalgia, and weight loss are non-specific and may be difficult to interpret in these debilitated patients. So this will cause delay for the diagnosis until massive ulceration or non-healing ulceration will occur. Regarding the approach to management of RA leg ulcers, if there is no clinical evidence of systemic vasculitis, ulcers should be managed in the same way as for any other patients with a leg ulcer. This may include moist saline dressings to help debride layers of slough from granulation tissue. In patients with exudative ulcers, occlusive hydrocolloid dressings are helpful. If there is no arterial insufficiency, compression bandage or stocking can help alleviate swelling due to venous stasis. If an ulcer fails to respond to these conservative measures, underlying rheumatoid vasculitis should be considered. Since this treatment involves aggressive immunosuppression, the diagnosis is best first confirmed by biopsy of the skin lesion of the ulcer. However, there are many types of rheumatoid vasculitis, so the diagnosis of rheumatoid vasculitis per se is not sufficient. We should also know which type of rheumatoid vasculitis. Rheumatoid vasculitis affects a range of blood vessel types. These include medium-sized muscular arteries, arterioles, and venules. Like other forms of systemic vasculitis, there is destructive inflammation of the vessel wall, which leads to vessel occlusion, tissue ischemia, and necrosis. Many of the serious clinical manifestations are caused by medium-sized vasculitis. However, sequelae of small vessel involvement, e.g. berbera and petechiae, also occur. Rheumatoid vasculitis can affect several organs, with skin, peripheral nerves, eye, and heart most commonly involved, so it is not only a skin disease. Deep cutaneous vasculitis is the most common and can also cause digital ischemia and gangrene. So, it may affect many organs, internal and skin, but the most common is deep cutaneous vasculitis. Peripheral nerve involvement is the result of vasculitic neuropathy characterized by inflammation of the vasa nervosum, which result in infarction of the peripheral nerve fibers. Depending on the distribution of the inflammatory process, both mononeuritis multiplex and distal sensory or sensory motor neuropathy can occur. All these are the types of rheumatoid vasculitis and should be managed as the each type need. Also, vasculitic neuropathy is typically rapid in onset and usually manifests as anesthesia. If treated promptly, most patients have a gradual although partial return of nerve functions. Ocular manifestations of rheumatoid vasculitis include scleritis and peripheral ulcerative keratitis (PUK). While anterior scleritis is readily diagnosed on clinical examination, posterior scleritis is more subtle, and the symptoms of visual blurring and ocular tenderness are important clues. Both forms of scleritis are intensely painful. PUK is characterized by the development of ulceration near the corneoscleral junction. Patients with PUK may develop the corneal melt syndrome caused by corneal keratolysis and subsequent perforation of the globe. This is a devastating complication as patients often abruptly lose vision in the affected eye, so it may cause sudden loss of the eye, sudden loss of vision, which is a irreversible condition. Pericarditis is usually the earliest presentation of cardiac manifestation of rheumatoid vasculitis. Arrhythmias can also occur, although it is often difficult to attribute these directly to vasculitis, as patients often have other relevant comorbidities. Acute coronary syndrome resulting directly from coronary artery arteritis is unusual. So the most common for cardiac involvement is pericarditis, but also arrhythmia may occur, and acute coronary syndrome is rarely or unusual to occur. So, what about treatment of rheumatoid vasculitis? As I said before, treatment should be guided by the type and the severity of the organ damage, type of vasculitis, and the severity of organ damage. Systemic rheumatoid vasculitis require aggressive immunosuppressive therapy, and therefore it is important to consider comorbidity. Treatment regimen usually start with a combination of high dose or even pulse glucocorticoid and cyclophosphamide, which parallel those used in primary systemic vasculitis. Glucocorticoids are accepted as playing an important role in achieving early disease remission, despite a lack of robust trial data. Pulsed methylprednisolone 1 gram daily or at least 5 mg daily for 3 to 5 days is used initially, and the patient can be switched to oral prednisolone after a few days. Maintenance therapy include azathioprine and or methotrexate. Treatment is guided by monitoring clinical response as well as inflammatory markers CRP and ESR and the marker of organ function such as urea and creatinine. Treatment is continued until disease remission is achieved. Cyclophosphamide is an established treatment of primary systemic vasculitis such as Wagner granulomatosis. Although no controlled trials have directly assessed the role of cyclophosphamide in the treatment of rheumatoid vasculitis, it is accepted as a first-line treatment, especially in severe cases or vital organ involvement cases. Of note, a small case series of rheumatoid vasculitis patients reported disease remission in all patients following daily oral cyclophosphamide therapy. If cyclophosphamide cannot be used, azathioprine is an appropriate alternative with corticosteroid. Methotrexate has been also used, although there is a limited evidence for its efficacy in rheumatoid vasculitis. The role of anti-TNF or TNF inhibitors in rheumatoid vasculitis is not established yet. Case reports suggest a positive outcome, although it should be noted that randomized trials have shown no evidence for TNF inhibitors in Wagner or GCA. So there is controversy about the role of anti-TNF because there is no positive data for primary vasculitis for anti-TNF. But anti-TNF is proved to cause remission in rheumatoid arthritis per se. So could it be helpful? This is an unanswered question until now. And finally, thank you very much for your attendance, and we will meet you tomorrow, inshallah. Wassalamu alaikum wa rahmatullahi wa barakatuh.